All right. Well, good morning, everyone. I'm Larry Boris, Executive Director of the National Association for Workplace Healthcare. I want to thank you for joining us for today's webinar. The topic today is the value of direct-to-provider healthcare marketplace. I'm sorry, did somebody said something? No? Okay. Let us begin. This program is being recorded, so you will have a link and slides available for you afterwards. For those of you who may not be familiar with our organization, NAWHC previously referred to the National Association of Work Site Health Centers. We have changed our name to include direct contracting and other kinds of value-based purchasing, and so that's why today's program is really so timely and important for us. NAWHC is the nation's only nonprofit focusing on helping employers, unions, and other sponsors and their partners for on-site, near-site mobile worker health centers, as well as direct contracting. We assist organizations in helping develop and expand their capabilities in this area, offering programs such as this one, educational services, benchmarking, networking, purchasing support, and information that can help both the purchasers and the providers in their efforts to offer great health benefits to their employees. Please visit our website when you can to learn more about our organization and the services. This is, as I said, this is one of many programs. We do mostly two programs a month. We usually have a first Monday roundtable, which allows about 30 minutes of content and then allows participants to share their experiences and information, ask questions to each other. And then we do a full webinar, as we're doing today, about 45, 50 minutes on a direct information content with a content speaker. So please put down these items, go to our website or LinkedIn group to learn more about the upcoming programs and how to register. These are all free for NAWHC members, and others, there's a small registration fee for that. So with that, today's speaker is Doug Geinzer, founder and president of High Performance Providers, who'll be sharing his experience and recommendations relating to direct contracting. But before we begin, do want to do a very short one-question poll to find out a little bit about the people here. If you didn't identify, please indicate if you have an answer directly. If you currently directly contract or you obtain healthcare services through direct contracts. So if everyone will submit their answers, we'll give you another 15 seconds to respond, and then we will show the results for everyone. This will help both Doug and myself in the kind of
Larry, we can't hear you if you're speaking, we can't hear you.
Can you hear me now?
You can now.
How's that? Can you hear me okay?
You can.
Yes.
All right, thank you. Okay, so the poll then shows that about 56% of those are already engaged in direct contracting, 33% are not, and then 11% are considering. So glad that we have a good idea, pretty split of the organizations involved. So with that, Doug, I'll turn it over to you.
Fantastic. Larry, thanks for having me. Pleasure to meet everybody that's on the webinar with us today. By way of introduction, my name's Doug Geinzer, and I am the founder of High Performance Companies, which includes high performance providers. I've been in the direct contracting bundled surgery business now for a little over probably 10, 12 years, building some of the first total joint bundles in the country long before the term bundle even really came about. We approached one of our local unions here in Las Vegas and asked if we put together an entire episode of care and charge them one singular price with guaranteed better outcomes if they'd be willing to do a little bit more business with us. They said yes, and then we quickly had to assemble and build what we now today call a bundle. So anyway, let's go ahead and we will advance it. I'm going to go a little bit deep in a few of these slides here. We will answer a bunch of questions at the end. I'll make sure that I leave 15, 20 minutes to do just that. But the slide that's in front of you right now breaks down what the typical medical spend is in your average health plan. I want to call particular attention to the center of it, where you see the inpatient hospital costs and outpatient hospital costs. Collectively, between those two, you're up in the high 30 range. And so that's the area that we could have the most impact when we're putting a cost containment solution in place for a health plan. A lot of times your benefit advisor, your third party administrator will come in, they'll replace the PBM with a transparent PBM, and that's an easy win to bring cost containment to the plan. But where the real cost containment can be found is in the direct care that's being delivered. When you start looking at the amounts that are spent out of the health plan, the largest bucket comes out of the surgical costs. And when we're looking at this, we're not looking to impact the investment made into dermatology or primary care necessarily. We're really looking at the high cost steerable events. So when you think of knees, hips, spine, bariatric, general surgery, kind of those areas. And again, I've been in the space for quite some time now. Go back 10, 15 years ago, and we talked about centers of excellence, which still exist out there today. And they all started focusing on just those areas, and they've continued to expand. What should be known is that, where the bulk of these costs come is in the site of care or the facility fees. And so it's important to recognize that about 70 to 80% of the surgeries that are being done out there today do not need to be done in a hospital setting, which is where you get that high cost of a facility fee. And for those of you that may be new to the term bundling or an episode of care, in your normal surgery, there are four distinct cost centers. You have your facility, your surgeon, your anesthesia, and your implant. And when you're building a bundle or an episode, you typically take all of those, you put them into one amount, and you extend some type of warranty or a guarantee on the quality that you're going to deliver. Most of those today are 30 days episodes or 30-day warranties. In the old BPCI days, we saw the 90 days that were common then. But typically in this scenario, most people are looking for a 30-day episode of care. By just changing that site of care, we're going to be able to find about a 50 to 70% cost containment in that facility fee, which is a tremendous amount. So when you look at, and we'll go into a case study later on, a total joint replacement, a total knee or a total hip, you're going to see variability in that pricing across the country and across the settings. I've seen total joints for as low as $12,000, $14,000, and then I've seen them as high as $180,000 and $200,000. So there's quite a bit of variability. When you get into direct contracting or bundled surgery, it brings predictability, it brings continuity and consistency in that pricing because you're going to know that, hey, I could now get a total joint replaced for an episode of care or bundled cost of $24,000. And that's just a roundabout number. You're going to see variability depending on the geography. Obviously, a total joint replacement in a New York City or a Boston is going to be much greater than a Wichita, Kansas, or a Reno, Nevada, just because of the cost of living in those particular markets. But really, again, I want to emphasize a lot of this comes down to the site of care. And I'm going to spend a little bit of time in a future slide talking about why that's important and how that site of care not only affects the pricing of that, but it also affects the quality of it, which a lot of folks don't recognize until they move it to a independently owned ambulatory surgery center. If we could advance the slide, that'd be great. This is the slide that I'm going to spend the most time on. The important thing to know when you're doing direct contracting is that we're eliminating all of the unnecessary third parties that are in that transaction. So the three parties that really, really, really matter are the ones that benefit from this type of arrangement. So I call it the three Ps, the plan, the patient, and the provider. So we're going to start with the plan experience. So again, when I'm talking about a health plan, we're really talking about the employer and in particular a self-funded employer. Important to know that this strategy does not work in a fully insured plan. It will work in any type of self-funded plan, whether that is a fully self-funded plan, a captive, or even a level funded plan, even though those get a little bit trickier. But with the plan experience, the person that's really writing the check, the employer, where it's they're paying the cost of this care out of the plan assets, they're going to find on all of these redirections about a 40 to 70% cost containment. So they're going to bring that total joint replacement from what their average may be, 80 to 100,000 down to that $24,000 mark that I mentioned earlier. That's a big deal for these employers. They're very excited about that, and they just need to figure out how do they get member engagement or patient engagement. We'll spend a little bit of time on that later on in the webinar. The important part about a direct contract, it eliminates the noise and it eliminates the balance bills that typically come with that. A common type of plan that we're hearing more and more about is RBP, or reference-based pricing. They're getting much, much better than what they were 8, 10 years ago when they first entered the market. But with a direct contract, most times it's at a bundled rate. And so we know exactly what that fee is going to be. If you're doing a direct contract at a percent of Medicare, you may be contracting at, call it 120% or 140%. And again, you're going to need to think about that in those four different components of a surgery. The one that's most important, again, I'll go back to it, is the site of care or the facility. When you're getting into direct contracting, you're able to build somewhat of a narrow network or a high performance network of providers. So it's not like your typical carrier play where the plan member is calling their navigator or their nurse or just looking at the provider directory, and it's a crapshoot as to who they're going to go to. Sometimes those things go in rotary. Sometimes it's, hey, this person plays golf with my primary care doctor. They went to a college that I'm familiar with. With this, you're able to narrow the network down. When we are building a direct contracted network, I oftentimes refer to a Noah's Ark close. I try to go into a community and I'll try to identify 2 to 3 providers of each category. So 2 knee surgeons, 2 hip surgeons, 2 gut surgeons for your lap choles and your hernia repairs, 2 cardio. And that gives the member choice still. They still want to feel like they're not being steered to a low quality provider. They want to know that they're getting a higher level quality provider. And you're going to be able to support that, or your nurse navigation firm will be able to support that through quality ratings and outcome measures. And we could spend a little bit of time on that as well. The important part is you're going to get a better health outcome. And a lot of people ask, how is that possible? And I'm going to spend a little bit of time on this from the facility standpoint as well. So it could be the same exact surgeon. And when a surgeon shows up at the hospital to take on a case, and call it a sports medicine, an ACL repair, or call it a total knee replacement, when they walk into that operating room, there's many times that they don't recognize the team, and it is a team. It's a theater, is what we call it in the OR, that's surrounding the OR table. That OR is managed, controlled, and administrated by the administration of the hospital. So it's the administrative picked anesthesiologist or the panel of those, the scrub tech, the rotating nurse, what have you. So that continuity that comes with just the instrument handling is critical. So there's a vast difference when that surgeon takes that same case, the same patient, into their owned ambulatory surgery center. Because in that OR, they are picking the team, they're assembling that team, and it's the same group. And I'll give an example with a surgeon that I've worked with for a couple decades now. When we started doing total joints in the ambulatory surgery center, everybody kind of called us crazy about it. Now it's standard of care 10, 15 years later. In the hospital today, even the average time in the OR for a knee or a hip is in the hospital is in the 38-minute range, 43-minute range, somewhere in that area. As where when we take that patient into our own ambulatory surgery center, we're able to get that patient out of there in 28 minutes just because of the continuity of care and the instrument handling that's in there. That 10 to 15 minutes makes a great impact in the recovery of the patient, in the cost that is associated. Obviously, with anesthesia, they're charged a per unit fee. But more importantly, we're able to get that patient up ambulatory and walking quicker because the anesthesia burns off because they're not under as long. So super, super important. Another area is a warranty. So think of a mistake going on in a hospital, whether it's a complication, whether it's an infection, whatever that may be. The hospital looks at that resurgery as another revenue opportunity. They get to bring the patient back in, they get another facility fee, they get another set of professional fees for the surgeon and the anesthesiologist. As we're in the surgery center setting, we often will ask for that ASC to provide some type of warranty. I call it a you break it, you fix it. So if the member comes out and they get a slight infection on the wound, that surgeon is expected to bring that patient back in, get them to higher quality of an outcome, and it's on their dollar. So that's the important part. Some of the providers will wrap that with some type of risk-bearing insurance, where they'll cover that risk. That's more common in, call it bariatric surgery, where the complication rate used to be way higher than it is today. Back 10 years ago, that could have been 10, 12, 15%. Nowadays, it's sub 3%, but it's important. Concierge employee treatment. The way that a member is greeted and welcomed inside of a surgery center compared to a hospital setting, night and day. Think about the last time that you presented yourself at a hospital. You see somebody behind the window and you only hear the terms driver's license and ID card, please. It's not a very welcoming setting, and then you're sitting on a uncomfortable vinyl chair, waiting a lot of times for hours before you get called back into the OR. The ambulatory surgery center, very much better managed, and it's more of a concierge-like experience. And what all of this does is it allows us to return the employee back to work and back to productivity sooner. So I always use either our total knees or even our hernia repairs, where typically when they're coming out of a traditional setting, they may be out of work for 2 or 3 months, as we're in an ambulatory surgery setting, we're able to get them back to work in 2 to 3 days. If we can go back one slide, I want to go through the other two areas of that. Want to reverse that 2 slides, please. There we go. So we're going to move on to the patient experience. This is what's the most important. This is our customer. For them, it's affordability. And a lot of people say, how can you find affordability in a direct contracting relationship? And it's typically done through the plan design, where the health plan will waive the copay, the deductible, and the coinsurance for that member for choosing the direct contracted provider. And so, yes, they may need to drive an extra 10 or 15 minutes, but when you're looking at affordability, and we're going to use hernia repair for this example, in a hospital setting, many times hernia repairs will cost $30,000 or $40,000 on average, as where we could get that done in an ambulatory surgery setting for $6,000 or $7,000. When that member walks in and they're on a high copay scenario, and they have to, they've got a max out of pocket of $7,000, and or they've got their 20% copay, take a $40,000 procedure. Before they even look at their max out of pocket, they're already $8,000 out, which is higher than what it would cost in a surgery center to begin with. So the employer incentivizes that member to go to the right place of care by waiving the copay, the deduction, and all of the coinsurance that comes with that. It's a great experience for the patient because they can now afford surgery that they once weren't able to afford. This is very important. There's a lot of times we'll start working with a health plan and the members are going, I haven't been able to get my knee replaced for 4 years because I just don't have $10,000 in the bank to cover it. The new health plan allows me to do that. The member's happy because A, they get this procedure done that they've been wanting to get done. They can return to life, picking up their grandkids and walking around with their spouse or loved ones. So it's important to them. Better health outcomes. Again, we talked about the uh, lower complication rate, lower infection rates that come with the surgery center, because in a surgery center, it's usually single site of care or single specialty of care. So in a hospital, it's not uncommon for there to be a gut surgery one moment, and then right after that, maybe a cardio surgery or an orthopedic surgery. So it's just there's a higher incidence of complications or infection. So surgery centers are a little bit cleaner of an environment. There's not as much what we call bad stuff floating in the vents because people opt to go to the surgery centers. They're not sick as we're in the hospitals. We're treating a much sicker population. We touched a little bit on the low to no infection. There's several surgeons that I work with around the country that are now on year 3, year 4, year 5 with 0 infections. Uncommon in most of the hospital settings where I think the average right now is about 8%. They enjoy the concierge patient treatment. They enjoy getting to know the doctor and the staff. They know that they're not going to receive a balance bill because the employer was kind enough to waive their copay deductible and coinsurance, and they could return to life. A lot of these folks just want to get back to playing with the grandkids, walking around the streets to talk with neighbors, and this allows them to do just that. The next area that we're going to touch on is the provider experience. I'm a provider guy through and through. That's who my clients are. Providers love this opportunity because it provides them a predictable, better reimbursement. And a lot of people say, how can you get a better reimbursement out of this? Isn't this treated like cash pay or low pay or, in that scenario? And it's absolutely not. The providers are able to establish their pricing. They're able to put in a good margin. It will become, when you start looking at your payer mix, it will become your highest reimbursing payor. The important part is, and how that comes about, is we're eliminating that administrative friction that lives in the typical traditional insurance world. We call it the billing, coding, appeals shenanigans. That goes away. I've seen some of these facilities, their administrative staff and their billing coding staff is now 2x what their clinical staff looks like. That all goes away because you know exactly what you're going to get paid before that patient even comes in. And many times the payment is waiting either in an escrow account where the funds get released the next day, or they're going to get released in 2 or 3 days. I've seen maybe the worst case scenario would be 15 days post-operatively you're getting paid. But again, all of that administrative friction just goes away. Getting out of the patient collections business is a big deal. We've always heard that the average collection ratio of patient collections ranges. Typically, it sits around 20 to 30%. So the rest of it is being written off as bad debt after you pay those billing, coding, and your collectors to try to collect upon the patients, which just gives a bad experience. The patient holds resentment towards the provider, which is ill-focused because it really should be geared towards the commercial payer. And in this case, that goes away. Easier pre-auth. We all hear the headaches and the problems with pre-auth nowadays. In a direct contract or a bundled surgery arrangement, by the time that referral gets to the office, it has already been pre-authorized, and many times it's been pre-funded. So the money's just there waiting to get collected upon completion of that surgery. So you don't need to spend hours and hours on the phone trying to get a pre-auth and peer-to-peer conversations. We already touched on the reduction of cost to administer. This one's important. The surgeons can earn more. So again, going back to the 4 components of an episode of care or a bundle: facility, surgeon, anesthesia, and implant. When that surgeon takes a case to the hospital, they're getting paid that it's a known amount. It's typically tied to some ratio of Medicare. And the surgeon's reimbursement rate has gone down. Most of my orthopedic surgeons said that they have not seen an increase in their reimbursement rate now for 20 or 30 years. So that is very, very important. They're able to earn more. And how is that? a lot of the surgery centers that I work with that have surgeons from different areas that come in and kind of lease the ORs, we're incentivizing them by paying them double pro fees, which makes sure that they're willing to take the call and they'll actually advance their surgery schedule for those patients coming in because they know they're going to get paid quicker, faster, and more. Very, very important. Scheduling efficiency. The ability to manage an OR in a surgery center, they just turn the OR much quicker. They're much more efficient rather than the hospitals where sometimes the surgeon finds themselves waiting in the doctor's lounge for 3, 4 hours, which time is money to these guys. So when a surgeon goes to a surgery center, many times my guys will start with 1 or 2 days a week that they go in to do these cash pay or direct pay cases. And they say, gosh, when I get to the point where I'm doing 4 cases that Friday morning and then I'm out golfing, those 4 cases pay them better than the 4 days that they do at the hospital earlier in the week. So the satisfaction with these providers goes up, which is important. And then return to the practice of medicine. None of these surgeons like the fact that they need to go through the pre-auth and the peer-to-peers. They really want to deliver high quality care to their patients, which is what they want to do. And by having a bundled case arrangement or a direct contracting arrangement, it allows these surgeons and practitioners to return to the practice of medicine. We could go ahead and advance the slide, please. So this is where it comes down to choice. On the left, you've got a large hospital system. On the right, you have a more modern-based ambulatory surgery center. The hospitals, we all know, there's a lot of patient frustration finding parking or parking in a parking garage only to find out that the OR that they need to report to is 3 blocks away and they're already hobbling because of that bum knee or hip. So it's just there many times with the surgery centers. It's a walk across the parking lot. Some of them even have valet out front, so it's fantastic. Fee for service, it's think of the number of bills that come in a fee for service world. We already discussed the top 4. Many times there's more than that when that surprise surgeon sticks his head in the door or the assistant or the advanced practice PA or nurse practitioner. Then all of a sudden you get a couple extra bills. There's the avoidance of all that is big for the providers. Hospitals have contracted anesthesia, as where on the ambulatory surgery center side, the surgeons many times are picking their anesthesiologist, which is very important. They work as a team when they go into that OR. And again, we get rid of the ID and insurance card. We talked about all of this. It's just a much better experience for all 3 parties that we touched on in the previous slide and the importance of that. We could go ahead and advance the slide, please. A lot of this all comes down to quality. So a lot of these self-funded employers nowadays are either hiring a medical management company or some type of nurse concierge. They may have, in this scenario, the direct primary care providers at the near-site on-site clinics navigating the patients to higher quality providers. The quality is important and it does vary from surgery center to hospital. I often look at these quality files and I'll look at Dr. Smith and you go, how can he range so wildly between hospital A, hospital B, hospital C compared to surgery center A, B, C, and D? And the answer is quite simple. It's the OR staff and it's the quality of the team that's doing the recovery post-operatively. And so again, when you move the site of care to an independently owned center, you're going to get a higher quality outcome, which is going to return that member to work quicker, and it's going to return them to life quicker. So the quality is very, very important. You're not going to be able to find that with employed physicians that are, basically mandated or incentivized through RVUs to refer the cases to the hospitals. These types of bundled case arrangements or direct contracted providers are typically found with independent providers. We know there's been a lot of shift in that space where obviously the larger systems, both the hospitals and the carrier systems, have done a lot of merger and acquisitions of buying groups. So it's a little bit harder to find independent practitioners than it was 5, 10 years ago, but they are out there. There are networks of them, and there are platforms where people can find those to make this whole process that much easier. We can go ahead and advance the slide, please. So this is just a case study to kind of talk about a total knee replacement. We talked about these sometimes ranging in the 70 to 80 range. I've seen some total knees get in the area of 180 to $200,000. For sake of simplicity and to keep it conservative, we just used a PPO cost of $53,000. As where if you went to a direct provider or a bundled surgery, it would only be $23,000. Where does that delta, where does that difference come out of? Well, the first part of it, the member responsibility, is going to be that 20% copay. And if they have a high max out of pocket because they've got a large family or they're on just a high deductible health plan and they haven't exhausted any of their first dollars yet, that member could possibly be coming out of pocket $14,600, which is a significant amount. And then the plan's going to make up that difference. So if the member did not have a high deductible, but and even a low copay or coinsurance, if that number went down, the amount that the health plan, the employer would be paying would go up. So in this type of scenario, again, the three parties that really matter are the ones that win. In this particular case study, the employer is saving a significant amount of money in this area, that 30, 40%. And then the plan member is coming out of pocket zero. So that really, for an employer, that helps the employer with the recruitment and the retention strategies and gives their plan a higher member satisfaction. Very, very, very important here. We can go ahead and advance the slide, please. This is a book that we published a couple years back. The QR code will lead you to it. It's a free download. It's, 30, 40, 50 pages. And I think I'll tell the story about why this was published. So I built several of the largest direct contracted networks in the country, brand names that you would recognize, whether they're center of excellence groups that service the Fortune 500 groups, or they're the smaller surgical bundled companies that may service the 50 members up to 5,000 members. But every single year we would take a look at the utilization and saying, how many of the plan members actually took advantage of this direct contract and went to it? And we would see variability from zero all the way up to one of our highest performing plans out of South Texas had 73% of their members properly redirected to imaging and properly redirected to surgery bundles. And in that scenario, I think they had 53 or 63% redirection to surgery bundles. If you took that and applied that to just a 5% utilization, it's night or day. That's where we get that delta in the gross savings of 30 to 70%, because the more utilization, obviously, the more savings for the health plan. And so when we exited a couple years ago, we said, how do we change that? And what it came down to is care navigation, nurse navigation. We hear different terms for it. I like the term really redirection. And we went, wow, we have written thousands of these direct contracts in all 50 states across the US. They're everywhere, like small towns all the way up to large metropolitan, your top 40 MSAs. It comes down to utilization. We said, what is the difference between those that are getting 50, 60% utilization compared to those that are getting 4%? And it came down to navigation and how quickly that care navigator, whether it's direct primary care or whether it's a nurse navigator or medical management, how they could get to that patient quicker and more effectively. And so I use surgery as an example because that's where most of this is done. And if you think about it, there's not a surgery that is done without an image being done first. And so we would look at the claims data and we'd say, okay, let's look at all images, MRIs, X-rays, CTs, what have you. And let's look at what that member paid or did not pay or the plan paid. And let's do an outbound phone call campaign. And so that member that was steered down the hallway of the hospital for an MRI, and that MRI cost the employer $8,000, and the member came out of pocket 20% or $1,600, and God forbid they were on a high deductible health plan and all 8 grand was their responsibility, we would say, hey, you made a bad choice. If you went across the street to the independent imaging center, we could have got that MRI done for just $600. And you would have saved all of that money because we would have waived your copay deductible and coinsurance. That's the first point of Intercept, and it's an educational moment. Then, what most of the nurse navigators do is they say, while I have you on the phone, what's going on with the MRI of your shoulder? Is it something that is going to require physical therapy? If so, did you know that we have physical therapists that we have direct contracted? Is it going to require surgical intervention? Is it going to require just an injection? And then they're able to help that member navigate. When that member takes that back to the water cooler the next day and they say, wow, I was able to get my next MRI done. I had to get my left knee done after my right knee. My first MRI had to come out of pocket a couple $1,000. The second one, I came out of pocket zero. That starts improving the navigation. So this download, when you look at it, it's really written for the employer, the health plan, and the third-party administrator, and it gives you the playbook of how to deploy an effective direct contracting strategy. Everything from the SPD amendment that is required to be inserted into the plan to allow this to happen, because you're going to want to create almost an out-of-network benefit that gives the member option or choice. And then it shows you how to get that claim paid for out of plan assets and send the accumulator up to stop loss or to the carrier if that's who's covering your stop loss, so they can keep track of that. But it really shows you how to deploy it. And it really talks about what are the main areas. So if you think of utilization, highly utilized services, they may be low cost, but they're high dollar volume inside of the plan, are going to be your images. And then if you think of even something such as colonoscopies, a lot of those being done. And if you could get ahead of it, think of what the downstream costs that you're able to avoid by being able to communicate with the member, getting them to a direct contracted provider. And if there is early indication or an early warning of something, that you could keep them on that direct contract provided pathway. Download this book. It is a fantastic read. If you have any questions, I believe my contact information is in the back of the book. Very accessible, happy to answer any and all questions regarding that. And I think that may bring us to the conclusion of the presentation. You've got my mobile number there. For those of you that like to text, my email could be found on all of the books. My team is here and willing to answer any questions that you have, and happy to point you and your staff in the right direction on that. So Larry, thank you, and I'll field any questions that may have come in along the way.
Great. Thanks so much, Doug. So at this point, I'm going to go around the table. And for all of you who are listed on the participant list, I'm going to call your name and ask if you have any questions or comments. So please unmute your computer when I get to you, and please do participate. So Dana Kirk, please, comments or questions? Dana?
Yes, I want to first of all thank Doug. I think the information that he shared is super helpful. We are not currently doing any direct to employer contracting right now, but the information was really good, and I'm just so very grateful for the education and the data that he shared. And Doug, I do have your number, and I may be reaching out with some additional questions that I may come up with. So thank you.
You bet. Happy to help anywhere I can.
Thanks so much. Angel Meadows, Angel, comments or questions?
Yes, thank you, Doug. A lot of great.
Could you increase your audio? We can't hear you, Angel.
Can you hear me
No,
now?
we can't.
Oh, can you hear me?
There you go.
Okay, thank you. Doug, great information. I have no questions at this point, but great information. So thank you.
Thank you, Angel.
Thanks very much. Jocelyn Van Linden, Jocelyn, comments or questions?
Hi, Hi, I do not have any questions at this time, but I thought it was a wonderful and very informative talk, and I will definitely be looking at the book.
Great.
Thank you,
Thanks
Jessica.
very much. Lillian Shields, any comments or questions, Lillian?
Hi, Doug. Thank you. Our question here at Intermed is there anything that you would either amend or delete from your presentation if you were considering direct contracting for either primary care or an on-site clinic?
So primary care and on-site clinics are really the hidden weapon in all of this. When I talked about when we dig into the utilization data, the plans that were the highest performing plans all seem to have some type of direct primary care into the plan, and in particular, a near-site on-site clinic. There was one group out of, I believe it was Oklahoma City, that offered their members 3 different ways of accessing primary care, but there was only one pathway to get to a bundled surgery or this direct contracting, and that was back through one of the near site clinics. It was hands down the best design plan that I've ever seen. So the near site on site clinics absolutely play a huge role in this. And I believe there's a big opportunity for them to even grab more market share with that type of strategy.
Thank you.
Great. Thanks very much. Doug, I think that's it. We very much again appreciate your participation and those who were on the call. Again, we'll be sending out a recording and copy the link to everyone on the call. And with that, have a great summer. Hope you can join us for our next programs in August. So everyone, have a great day. Bye-bye.
Thank you, everybody.